Okay, so we're going to continue with the program. Our next speaker is Dr. Victor Suarez, who is a neuroradiologist and works at Clínica de la Universidad de Navarra, but this is the site that is in Madrid. So welcome, Victor.
Thank you very much for the introduction, and also I'd like to thank the Congress organization, the ARRS, and the CERAM for this invitation. So let's talk about imaging evaluation in tumor response. Unfortunately, I have nothing to disclose. So this is the general roadmap of a patient who comes to us to scan the brain of a patient with a brain tumor. The patient comes to us, the patient is diagnosed with a brain tumor and goes to the so-called STOP protocol, which is the standard of care, which consists of surgery as resective as possible and chemoradiotherapy. Okay, so the tumor is resected as safely possible, and the patient can come back with another enhancing lesion. And for the evaluation of this recurrence or this new lesion, we apply the so-called RANO criteria, which are based on the size and the enhancement of the lesion, and we can face these imaging changes related to the treatment, which are the pseudoprogression or the radiation injury. But to be honest, the radiation injury actually can be seen during all the process. If the patient has a relapse or recurrence, goes to second-line treatments, which consist basically in the anti-angiogenic therapy, the anti-VEGF, and the immune therapy. We are in the new era of the explosion of the immune therapy. And linked to these new therapies, we can have the pseudo response, and the RANO criteria are changed to the iRANO criteria. So in 2010, the Journal of Clinical Oncology published the RANO criteria, the response assessments in neuro-oncology, which are the current standard for assessing treatment response for high-grade gliomas as well as lower-grade gliomas and astrocytomas. But this is usually not so easy. The RANO criteria defines the measurable disease. What is the measurable disease? When we talk about measurable disease, we're talking about enhancing disease on post-contrast imaging. It defines a minimal diameter of 10 millimeters. In order to clinical trials, we can be asked to measure the sum of products of the perpendicular diameters, and this is done this way. And at least 2 lesions are to be measured if more than one is present. 2 small lesions cannot be measured reliably, and this is why the magic number of the 10 millimeters. So this is a small lesion, of course, has to be addressed in the clinical report, but they are not included as measurable disease. Some problems, some issues with the measurable disease, when we have lesions around the cyst or a surgical cavity, are to be considered as non-measurables unless there is an enhancing component meeting the measurable disease criteria. For example, this is a relapsing multicentric glioblastoma. This is the surgical cavity, and we have this new measurable disease or enhancing lesion adjacent to the surgical cavity. This can be addressed as a measurable disease. Lesions with a necrotic component can be selected as a target if they are the only lesion present. And the necrotic cystic part is unlikely to shrink even in responding tumors. We have this necrotic ill-defined glioblastoma, high-grade tumor. In this case, we can measure, we have addressed this as the target lesion. What about the non-measurable disease? When we talk about the non-measurable disease, we are talking about the T2 flare abnormalities. Their introduction in the RANO criteria was secondary to the new treatment of the anti-VEGF treatment, anti-angiogenic treatment, and is associated with pseudo-response. We'll talk about it later. To talk about progression disease, this increase in the T2 flare abnormality has to be significant. Here's an example of a oligodendroglioma with this ill-defined, very high, hyperintense T2 lesion in the frontal lobe with a midline shift. The enhancement of the lesion is more or less is pretty ill-defined, and I put here the 3D sagittal flare just to see how this lesion invades the corpus callosum. So this patient goes to surgery, and the post-surgery evaluation, there's an extensive resection of the tumor, but there are some areas of high T2 and flare abnormality. In the follow-up, we can see that these lesions are not really enhancing. We cannot talk about an enhancing measurable lesion, but when we look at the flare images, we see that despite we can more or less define this edema or vasogenic edema, there are some areas or The hyperintensity is not the same. They are they are nodular, they are pseudotumoral here and here and here, and these crossing the midline and affecting the contralateral hemisphere, this tumefactive T2 flare abnormality, and this was consistent with recurrence or a tumor. And this is the imaging of the methionine PET, which is, matches the results of the T2 flare abnormalities. But sometimes these T2 flare abnormalities, they do not need to be so big. We have a grade 3 astrocytoma, which is resected. This is the T1 post-contrast. We have the surgical cavity. And in the FLAIR imaging, we have this tiny, round, small hyperintensity. We just reflected that in the clinical report. And in the 2 months follow-up, this hyperintensity becomes more nodular, more tumefactive, appears this nodular enhancement. The perfusion imaging show a mild increase in the CBB, in the cerebral blood volume, and this is the methionine PET, this was consistent with a tumor relapse. The RANO criteria defines this criteria of complete response, partial response, stable disease, and progression disease. Important to notice is that to label a patient with a complete response or a stable disease, they must fulfill all the criterion. But when we're talking about progression disease, 2 weeks after the initiation of chemoradiotherapy, fulfilling any of the criterion, we can say that this is progressive disease. And during the first 2 weeks after the initiation of chemoradiotherapy, only a new enhanced lesion outside the radiation field defines progressive disease. Talking about what we can face with a patient, let's talk about the pseudoprogression. It is radiologically defined as a newer or enlarging area of contrast agent enhancement related to treatment which simulates progressive disease. It is believed to be related to endothelial damage. It is usually seen in the first 3 months, although it can be seen 6 and even further months after the initiation of therapy. Is far way more common in a combination of the chemotherapy, the temolfluramide, with methylated MGMT tumors, and really conventional MR cannot distinguish between really progressive disease and pseudoprogression. Here is an example of a patient which comes to a high-grade glioma. The glioma is resected, and the 6 months follow-up imaging, we can see these tiny micronodular enhancements around the surgical cavity. In the 8 months, 2 months later, in 8 months follow-up, these enhancements become bigger, thicker, and the edema also increases. I put here for you the perfusion imaging, which is really not increased. And if we follow up this patient, 10 months, it becomes, the lesion begins to enhance a little lower, and the edema decreases a little bit, and in 13 months follow-up, this almost has completely disappeared. So, to be honest, the diagnosis of the pseudoprogression to be established as a firm diagnosis is made retrospectively. When we're talking about progression, this is as Dr. Autrilla talked in the talk earlier, the differentiation between progressive disease and pseudoprogression most of the time is made retrospectively, the diagnosis. What can advanced imaging, the role of advanced imaging can aid us in this diagnosis? For example, in this patient with an astrocytoma grade 3 H mutant, comes with the lesion. The lesion is completely resected. This enhancement here is not this area here. It's a new enhancement lesion. When we see the perfusion map, 3 months follow-up, the CBB volume has a ratio of 2.1 compared with the contralateral healthy tissue. I think that we must refer, as far as possible, in our clinical reports, we will talk about the ratio in the perfusion, because the perfusion, this is our semi-quantitative maps. We must not stop just in the qualitative evaluation of the colors. I think we must issue and address in the final report the ratio for a semi-quantitative address. In the follow-up, the lesion becomes bigger and a little more of edema, but the perfusion, which was here 2.1, the ratio begins to decrease, and even in the follow-up, the lesion practically disappears. So in the literature, there are a lot of papers, but we are radiologists, we like to talk about thresholds values, and between 0.9 and 2.1 mean CBB ratios. We can talk. We still are in the probability of a pseudoprogression. Here is the general picture of treatment-related changes when talking about spectroscopy, with a decreased NAA, but also decreased choline and creatine. And this is the imaging in contrast of a recurring tumor, where a very high choline peak and very low NAA, and also a negative doublet of lipid lactate. When talking about another advanced imaging, we can have here a high-grade tumor, or relapse. There's a T2 very heterogeneous lesion. Most of it looks like solid component, but when we look at the contrast-enhanced lesions, there is a very necrotic prominent component, and there is this nodular enhancement. It has a very increased perfusion characteristics, and this is some of the new tools or new sequences that can be used in the for assessing tumor response. This is the APT, the amide proton transfer. We are beginning to use it. It's a kind of chemical exchange saturation transfer, and it measures the acidic microenvironment of the tumor, measures the interchangeable NAH groups between the proteins, and curiously, the solid and more, let's say, cellular part of the tumor is not so acidic, and it's the necrotic part of the tumor which has increased acidic component. This is another patient. We came to us with a primary cerebral sarcoma, goes to surgery, complete resection of the tumor. This is the 4-month follow-up. And after 20 months of follow-up, it begins to appear this nodular enhancement. This is some triangle-shaped enhancement here, and this arch-like enhancement here. The perfusion was not elevated. The SWI map shows areas of microbleeding and hemosiderin. So we said, okay, this looked like a radiation necrosis, radionecrosis, and we made a mistake. We performed spectroscopy imaging. The study was of very good quality, and this was a very ugly spectroscopy, a very high choline peak, very low NAA. The choline NAA ratio was of 5, so we said, okay, this spectroscopy was about this triangle-shaped lesion I show you here. So we said, okay, it looks like radiation necrosis, but probably is relapse of the tumor. The patient went to surgery, and everything was radiation necrosis. So the message here is never focus on just one advanced imaging. If the whole study suggests is radiation necrosis, do not take only one advanced imaging as the complete truth, because also this patient had a methionine PET, which was positive also, and was labeled as progressive disease, and there are false positives. Very inflammatory radiation necrosis can mimic progressive disease. So bear in mind and do not rely just in one advanced imaging and take the study as a whole. We are in the era of immunotherapy. There are a lot of therapies, the checkpoint inhibitors, which are some of them are the most used are the nivolumab and pembrolizumab. In our center, we have 2 clinical trials going on with adenovirus, with oncolytic virus where directly injected in the tumor, one for diffuse for DIPG, another for high-grade tumors, and we have another trial with this proteasome inhibitor. This is the general picture of a patient with immunotherapy. The patient has a relapse of the tumor and is put on checkpoint inhibitors, in this case nivolumab. And during the follow-up imaging, what we have to take into to bear in mind, and the anti-tumoral effect of the immunotherapy takes time. And after 6 or 7 months of the therapy, the lesion continues to grow and the edema increases. So you have to be very careful, do not to report here as progressive disease. Otherwise, the patient will draw out of the treatment, and we will not see the anti-tumoral effect that can last some months to appear. Because of this, the RANO criteria were modified to the I-RANO, I for immunotherapy. And not going to go to all the classification, but very important item to take in mind is does a new lesion defines progressive disease? Well, in the RANO criteria, yes, a new lesion defines a progressive disease. But in the I-RANO criteria, if the lesion appears after 6 months of the start of the immunotherapy, yes, it's progressive disease, but during the first months of treatment, we have to be extra careful and not to say progressive disease, because that can be an image which can be attributed to the immunotherapy. And we need a 3-month imaging confirmation of worsening of this new lesion. This is a patient of our institution with a pretty small necrotic lesion, which was surgery and was a GBM. During the follow-up, 1 year after surgery, the patient appeared with this new enhancing solid lesion. This is the methionine PET, confirming this is a recurrence. The patient went into the clinical trial, and the neurosurgeon injected directly the virus inside the tumor. This blooming artifact is the virus is injected with a drop of gadolinium, just to double check that you are really in the site, you are really where you wanted to be. Here are the bubbles during the surgery. And in the follow-up, you can see that the lesion begins to shrink. The anti-tumoral effect takes a little bit time, takes time to visualize, but in the follow-up, the lesion shrinks. Although the Rano criteria only talks about perpendicular diameters, as far as possible, it is also very interesting to address the volume of the lesion in your reports. And this is very valuable information for the neurosurgeon and for the oncologist. And last, let's talk about this effect, the cell response, which is strictly linked to the new anti-VEGF therapies. It's defined as a rapid decrease in contrast enhancement and edema without any significant change in actual tumor size. That is, the tumor does not enhance, but really it is there, it's not gone. It has a high response rate, about up to 60%. We can see this antivascular effect as early as the first hours after the initiation of the therapy, but the modest effect on the overall survival is very modest. There is a persistent elevation, however, in the perfusion and the diffusion values, and the use of these therapies defines a new progression pattern, which is the enlargement of non-contrast enhancing lesion, which is really non-contrast enhancing tumor. This is the general picture of a patient with bevacizumab. The patient has a relapse, is put on bevacizumab, and there is a dramatic decrease in contrast enhancement of the tumor, but the tumor really does not go away. It's still there. So we must focus on T2 flare abnormalities. And this is a patient for our institution, very big relapse of glioblastoma, high-grade tumor with a lot of edema. The patient is put on bevacizumab, and 2 months there is a dramatic decrease in contrast enhancement and also in edema. You can lower the dose of corticosteroids, so this is good for the patient. 4 months later, there is even a major decrease in contrast enhancement and edema, but eventually the tumor explodes, and both the enhancement and the T2 flare abnormalities becomes bigger. So to finally, the bullet points, or the take-home message of my talk, are that treatment-related changes might be difficult to differentiate from the tumor progression, and here we must aid because of the advanced imaging, perfusion, or whatever spectroscopy, or whatever you feel comfortable. This is an old phrase, oldie but goodie, always revise the previous exams if possible. Advanced imaging techniques can improve outcome prediction and assessment of treatment response. Evaluate all the sequences as a whole and never trust just in one sequence, although it is an advanced imaging. We are in the era of immunotherapy, and the Rano criteria must be taken into account. And new MRI techniques are here, as the APT, amide proton transfer, as I showed you before, but they still need to be tested for daily clinical use.